I'm Dr. van der Bijl presenting the second part of Lecture 1. A reminder that I will emphasize core concepts during the PowerPoint. Please refer to the study guide, the chapters in the textbook, and work through the case study and multiple choice questions to ensure that you have mastered the work. Simply going through the PowerPoint will not be enough to get you through the exams. We are going to continue with the theme of neonatal adaptation after birth by looking at physiological changes, the neonatal consequences of maternal conditions, neonatal depression at birth, as well as birth injury. Fetal monitoring during labor is important as it is a sign of good intrapartum care. A cardiotocograph or CTG can be done. It is an easy, non-invasive tool to use. The trace is evaluated for 4 basic features, namely the baseline heart rate, the beat-to-beat variability, evaluation for decelerations, which can be early, late, variable or prolonged, and to look for accelerations. When you interpret it, normal will be all features that are reassuring. With other words, a good baseline heart rate with good beat-to-beat variability, the absence of decelerations, and the presence of accelerations. Suspicious CTG would mean that there is one non-reassuring feature, and then with pathological interpretation, 2 or more non-reassuring features are present, which might indicate fetal distress or compromise and may necessitate assisted delivery or cesarean section. Fetal compromise is a term used to describe an at-risk fetus, so it's important to take cognizance of maternal, uterine, placental and umbilical causes that can place a fetus at risk for hypoxia and therefore the whole hypoxic ischemic encephalopathy sequence. Maternal factors such as preeclampsia, diabetics with microvascular disease or any chronic disease will put the fetus at risk. Hypercontractibility of the uterus during a labor process can limit the amount of oxygen transferred to the placenta and to the fetus. A prerupture placenta is an emergency as the baby is cut off from oxygenation and removal of CO2. And then in cord prolapse, which is an obstetric emergency, again the cord is compressed so that the fetus will not be able to oxygenate. In fetal distress, it basically describes a stressed fetus with signs of compromise due to severe hypoxia. And in that case, you really have to deliver the baby soon or he will have a risk of dying or having severe neurodevelopmental disability in future. We will quickly just review the physiological changes that take place at birth. Labor prepares the fetus for adaptation, and with the adrenaline surge in the mother, it will switch off the production of lung fluid and prepare the lungs for reabsorption of the fluid and for air breathing. The first hour, and specifically the first minutes after ligation of the umbilical cord, are important time periods to make these physiological changes in the respiratory and cardiovascular systems. The newborn will also have to start with thermoregulation and glucose homeostasis right after birth. The first breath is very important as it generates negative pressures to make sure that the lungs inflate, and the lung fluid can also be expelled or absorbed to allow gaseous exchange to take place over the alveolar membranes. As the oxygen tension increases after birth, this will facilitate the closure of the ductus arteriosus. There will be a decrease in the pulmonary vascular resistance, and with that fall in pressure and the pressure changes, the foramen ovale will close and the newborn cardiovascular circulation will be in effect. The intrauterine environment is extremely important for the health and the normal development of a fetus. If there is any maternal disease or behavior that influences this normal supportive environment, it can have dire consequences for the fetus and for the neonatal development. Teratogens, the definition is a chemical, drug, virus or radiation agent that negatively affects the well-being of the fetus. In maternal infection, the inflammation can interfere with normal cell division, and even something as innocent as a fever may lead to a malformation in the fetus. One association would be spina bifida cystica if the mother has a fever during the first month of her pregnancy. Another example would be viral agents such as rubella, which we know has the most devastating consequences if the mother contracts this disease in the first trimester of her pregnancy. It might lead to congenital abnormalities with heart lesions, cataracts, deafness, and central nervous system abnormalities. The use of drugs during pregnancy should obviously be strongly discouraged, as a developing fetus has significant risks for developing systems during the substance abuse. One always thinks of amphetamines and cocaine, but remember that even alcohol and cigarettes have a negative effect on the development of a fetus. We are first going to look at fetal alcohol spectrum disorder. The specific dose for FAS to develop is unclear, but it is prudent to say that all alcohol consumption should be avoided during preconception, with other words, the planning phase for the pregnancy, as well as during pregnancy. It is most likely to cause harm in the first trimester or early gestation, or then if the mother chronically abuses alcohol over the course of her pregnancy. There are several clinical features that will guide you to this diagnosis. So firstly, you should have a history of alcohol exposure, so spend time and gain the mother's trust so that she can share this information with you. It will also cause intrauterine growth restriction, and after birth even can lead to growth failure with weight or length often falling below the 10th centile. You have specific facial phenotype, and specifically they might have the low nasal bridge with epicanthal folds. They can have short palpebral fissures with a smooth fulcrum and a thin upper lip, and micrognathia with minor ear anomalies, as you can see in the picture. The central nervous system damage or dysfunction is exhibited by measuring the head circumference and plotting it on the growth charts. You should see microcephaly, and as the child then grows up, there will be developmental delay. They might also have other systems affected, and it can lead to skeletal and visceral abnormalities. So it's good to screen for those other systems as well. Despite the overwhelming evidence of harm, many pregnant mothers are still smoking. It's estimated that up to 25% of pregnant women still smoke. Passive exposure to paternal smoking has nearly as great an effect on the developing fetus, which is quite a worrying finding. When a mother smokes, it impairs the uterine function, which can lead to placental changes, and in the end it increases the carboxyhemoglobin levels of a fetus, which implies that the fetus is hypoxic, and this will then stimulate erythropoiesis. The adverse effects in pregnancy include subfertility, an increased risk for abortion, fetal growth and intrauterine growth restriction is more common. It may also lead to placenta previa and abruptia placenta. Chorioamnionitis and preterm prolonged rupture of membranes are also present. In childhood, the most important risk factor for SIDS, apart from the sleeping position, is now deemed to be parental smoking. So this should be avoided around babies. There's also studies that show that children exposed to antenatal substance abuse like smoking has a high risk of hyperactivity with reduced stature and decreased mental function, and it may also predispose these children to malignancy. Chronic maternal medical conditions can have an adverse effect on the developing fetus. One such an example is baby of a diabetic mother, which we did discuss in last year. So I'm just going to quickly review that. In the antenatal stage, it's important for the mother to be well controlled during conception and to maintain that for the duration of her pregnancy. If this does not happen, they have an increased risk for miscarriage. They can also suffer intrauterine death. Embryopathy is congenital malformations that affects the fetus. Caudal regression syndrome is an example of this, as well as sacral agenesis, as you can see in the pictures. There might be hyperplastic left colon, an increased risk for renal vein thrombosis, and then all babies born to diabetic mothers should actually be screened for congenital heart disease, such as PDAs, ASD, VSD, or transposition of the great arteries. Fetopathy is also commonly seen due to hyperinsulinemia. With insulin being a growth hormone, the babies are often macrosomic, with the weight above the 90th centile as well as the length above the 90th centile. The typical growth pattern then is also for the head circumference to be within the normal parameters. Hypertrophic cardiomyopathy often happens, as you can see in the chest x-ray at the bottom. Intrapartum care should be optimal for a mother with diabetes, as assisted deliveries are much more common in this population, as are cesarean sections. The baby may suffer birth asphyxia because of the macrosomia and cephalopelvic disproportion, and the baby can also have shoulder dystocia with an increased risk for birth injury, specifically brachial plexus injury. When the newborn is managed in the ward, it's important to have a high index of suspicion for hypoglycemia, and there's also a strong association with hypomagnesemia and hypocalcemia that can lead to convulsions. The babies are often polycythemic, as insulin is a growth hormone and you have this fastly growing fetus in utero. Perinatal asphyxia is one of the most serious preventable causes of neonatal morbidity and mortality. Severe long-term sequelae such as mental retardation, cerebral palsy, blindness, and epilepsy can follow perinatal asphyxia. The fetus has protective mechanisms during contractions, and the response of a normal fetus to transient episodes of hypoxia during the labor process includes perfusion of the vital organs, which are the brain, the myocardium, and the adrenal glands. The stress hormones produced by the adrenal glands will ensure that there's a good perfusion blood pressure to maintain organ function. Blood is also directed away from the non-vital organs, such as the skin, bowel, and muscles. Another phenomenon we see is the diving seal reflex, where there is bradycardia with increased blood pressure that will ensure good blood flow to the baby's brain. Anaerobic metabolism can create ketones and lactate, which in the immature brain can serve as alternative fuels to oxygen and glucose. If the baby suffers a severe event or is exposed to chronic hypoxia, the adaptive mechanisms can be exhausted, and there are predictable responses in both the respiratory and the cardiovascular systems. So in the respiratory system, you can have increased respiratory activity, which will then progress to primary apnea, where the fetus will stop making breathing movements. This will then progress to gasping respiration, after which, if the condition did not improve in utero, terminal apnea will follow. Similarly, changes in the cardiovascular system include initial tachycardia that you can see on the CTG. This will progress to bradycardia. At this point, the blood pressure is still maintained. A transient rise in pulse rate may follow, after which the bradycardia will progress and hypertension may follow. The practical implication is that when a baby is born during the primary apnea phase, the newborn will start gasping, and with improved oxygenation, the heart rate will return to normal and the blood pressure will be maintained. However, if a baby is born in the secondary apnea phase, the blood pressure is so low, and as the baby is not going to make any further respiratory efforts, the baby will probably die. It is important to note that not all suppressed babies have birth asphyxia. It has major medical legal implications when you label a baby to have birth asphyxia. Therefore, the diagnosis must be made according to a set criteria. So the first thing is that you need a history of a major sentinel event, such as a rupture placenta. There should be evidence of birth depression, and you can use the APGAR score here at 5 or 10 minutes. And then you need proof of anaerobic metabolism. This we can do by performing an umbilical arterial gas where the pH is less than 7 and or a base excess of -16 or more. You can also do a gas in the first hour after birth. Neurological sequelae should be documented, and encephalopathy can be graded according to the modified Sarnat or Thompson scores into mild, moderate, or severe. There should be multi-organ system dysfunction present, and other etiologies must be excluded, for instance, infection, specifically meningitis. You can also exclude metabolic disease and congenital brain abnormalities. The differential diagnosis of birth asphyxia is quite extensive. So with a brain sonar, for instance, you can exclude congenital brain abnormalities or intracerebral hemorrhage. You can look for antenatal cerebral insults like antenatal strokes. And then you can look at all the other factors that you can exclude, and just a special mention again of infection. So you have to rule out meningitis, and these babies should probably all receive a lumbar puncture. High-risk pregnancy should be managed very well, and risk factors in the antenatal, intrapartum, and postnatal period should be taken into account when planning for the delivery and the management of the newborn. For resuscitation, please follow the evidence-based guidelines. And then, very important to focus on the post-resuscitation care to manage the early and the late sequelae that may follow hypoxic ischemic events for the fetus. So firstly, we're going to ensure that the baby has a good respiratory drive and that the cardiovascular system is making the necessary adaptations. And then there's a focus to minimize any further brain damage by preventing hypoglycemia. Also in term and post-term babies, we need to prevent hypothermia, which has been associated with poorer neurodevelopmental outcome. Babies can be considered for therapeutic hypothermia if they are term or near-term infants, and if they have moderate asphyxia according to the staging. Convulsions should be adequately managed and terminated, and then brain edema should be addressed. A fetus may easily sustain injury either during the labor or during the delivery process. It can be a result of inappropriate use of force, but sometimes it can also happen inadvertently during procedures to try and deliver the baby safely, as you would see in a shoulder dystocia. One of the most common birth injuries is a kephalhematoma, where there is bleeding between the periosteum and the skull bone. This can occur after birth and may worsen in the first few days of life, and it can persist for weeks or even months afterwards. Very important that it does not cross the suture lines. Associated complications include an underlying linear skull fracture, so be careful when you palpate a baby with a kephalhematoma. Then it may lead to anemia and jaundice due to extravascular hemolysis. When it resolves, it can cause quite a firm ridge as it calcifies, and this will then in time disappear. It may also be associated with intracranial hemorrhage, so if you have a baby with abnormal neurological signs, you can consider that it has happened. A subaponeurotic or subgaleal hemorrhage can happen when there is a bleeding beneath the aponeurotic sheet. The scalp typically becomes fluctuant, which is called the hot water bottle sign. This can follow after trauma during delivery, especially if there was a vacuum extraction, but it might also indicate a coagulation defect in the neonate. So because of the significance of the bleed, they can be severely anemic and might even present with hypovolemic shock, which might necessitate resuscitation fluids and blood transfusions. Obviously, extravascular hemolysis has to take place, and therefore jaundice should also be taken into account. When examining a baby, remember to look for symmetry of the baby's facial features. Facial nerve palsy can occur with lower motor neuron lesions, which can happen secondary to intrauterine pressure of the maternal sacrum on the baby's face, or it can follow on a forceps delivery where there's injury of the lower cranial nerve 7. Brachial plexus injuries are serious injuries that take place usually because of excessive lateral flexion, rotation, and traction on the baby's neck. And this often is associated with deliveries of babies with shoulder dystocia. The complete recovery can be expected in up to 50% of cases, but other babies might need physio and even nerve reconstruction. There are 3 types depending on where the damage to the brachial plexus is located. So Erb's palsy, you have damage of C5-6 area, and the typical position of the baby's arm is in the waiter's tip position with the arm in adduction, the elbow extended, and the forearm pronated, and the grasp reflex should be intact. There might also be injury to the lower branches of the brachial plexus where C7 to T1 are affected. This will lead to wrist drop with flaccid paralysis of the hand and therefore also an absent grasp reflex, as you can see in the photo. More rare would be a total paralysis of the arm affecting C5 to T1 with flaccid paralysis and even cutis marmorata of that limb. When a baby is admitted to the neonatal intensive or high care unit, they are very vulnerable to iatrogenic injury. When a baby is admitted to the unit, technology is often used to monitor their progress, and life support may be needed to stabilize a critically ill neonate. Medical management might be injurious and therefore should be closely monitored, and invasive procedures are common to ensure that the baby is managed appropriately. Close attention to detail is necessary to prevent these injuries from happening. Probes should be carefully and gently applied to the limbs. Make sure that there is no pressure sores and that you avoid circumferential strapping to keep the probes in place. Probe position should be changed every 6 hours to ensure that there are no pressure sores or burn wounds, because the light emitting electrode can also emit energy. Drips should be carefully maintained and removed at the first sign of infiltration or phlebitis. Nasal prongs are a particular problem when using a CPAP machine, as the masks are tightly fitting. So review the nose regularly to look for pressure sores and especially pressure to the nasal septum. Calculation errors are common, so particular attention must be paid to working out the intravenous and also the feed volumes for these babies. When a baby has suffered an iatrogenic injury, remember to clearly note the incident, and please counsel the parents adequately and ensure that they understand what has happened and what remedial action will be taken.